Voice America Health and Wellness.
Welcome to Psychiatry, Ask the Expert, hosted by Dr. Neil Kaye. All comments, views, and opinions expressed are solely those of the host, guests, and callers. Dr. Kaye will not diagnose or treat callers. The information provided is informational in nature. In the next hour, Dr. Kaye explores the inner workings of the brain and mind. Grab a pen and paper and sit back. Here is your host, Dr. Neil Kaye.
Good evening. Welcome to Psychiatry Ask the Expert. I'm Dr. Neil Kaye, and Jay Birch and I will be your hosts tonight on a call-in hour. We're going to encourage callers to call in with any questions they have in the area of mental health. Our call-in number tonight, 866-472-5792. Each week on Psychiatry Ask the Expert, we focus on a specific topic in psychiatry. We talk about diseases and illnesses, common symptoms and their presentation, and of course treatment options with a focus on psychopharmacology, the medication treatments used in psychiatry. We talk about potential risks, benefits, side effects, treatment alternatives, the dosing, the newer medications, and the older medications. Tonight, as I said, Jay and I are going to be discussing a whole group of issues in psychiatry, and we're going to encourage our callers to join us tonight and let us know what they are most interested in discussing.
Neil, are you comfortable in your chair? Because I have a lot of questions for you tonight.
Yeah, we're going to have a nice conversation tonight. This is actually week 12, and we've come a long way in 12 weeks, I think, and a chance for you and I to kind of review some of the things that we've talked about, trade some ideas around, and it should be a good show. I'm excited.
12 of these shows, and we're still friends. Take me to your radar screen. What's on your screen this week, Neil?
A couple different things on the radar screen tonight. The article on treating mothers who are depressed actually ends up helping their children. Not really surprising to me. Again, people fail to realize that mothers who are depressed can't parent as well when they're depressed. They don't have enough energy, attention, focus, concentration, and in fact, it points out that a mental illness affects not only the person with that illness, but other people close to them, friends, loved ones, acquaintances, colleagues, family members, that these illnesses actually have a ripple effect. Second one was sleep deprivation in teenagers. We talked about this a little bit last week. Another report out in the last day or so showing that the majority or a healthy minority of teenagers are not getting enough sleep, not enough refreshing, compacted sleep, bad hours, too much time on TV, stimulation, Xbox, Game Boys, and the like, and that kids need time to just play, kids just need time to sleep and get refreshed, and America, again, a sleep-deprived country. Last one is actually out of the European side, but a drug called Lyrica, now approved for generalized anxiety disorder in Europe. We are expecting that drug to be approved in the U.S., hopefully sometime later this year. Always a little bit hard to guess when the FDA will actually move on this issue. The interesting part about Lyrica is it would be the first non-addicting anti-anxiety drug that looks pretty promising, and we need some alternatives to the Valium class of drugs here. So that looks kind of interesting, and I think we'll probably see that approved at some point down the road. What's on your radar screen this week?
Well, Neil, it's interesting that coincidentally we're coming up on the 150th birthday of Sigmund Freud, who in many psychiatry circles is revered as the father, grandfather, god of psychiatry, if you will. Yet the point of the Newsweek article, and it is the lead article in the journal this week, is that a lot of Sigmund Freud's ideas, his psychoanalysis perspective, his techniques have become debunked, and new psychiatry has virtually taken its place. What are your thoughts on Sigmund Freud?
Sigmund Freud, obviously, the father of modern psychiatry. Like anything else, over time you learn that there were errors in some of his thinkings, and he was biased by his culture and his time. Yet at the same time, Freud, really an incredible scientist. you think about scientists, what they do best is they make careful, detailed observations about what they see, and Freud was excellent about that. He may not have always drawn the best conclusions, but he certainly documented what he saw very well. Turns out that a lot of what he was pushing for is right and very valid. It's just not very efficient in a medical system that really demands efficiency. And I know you and I are going to talk about this more tonight, but the desire to alleviate symptoms as quickly as possible. A lot of therapy techniques, in fact, a lot of medications, really targeted at rapid symptom relief and not necessarily at underlying problems. Freud's original approaches were much more focused on the root cause of a problem, less on symptom alleviation. The other thing that Freud talked about and is often forgotten is that he believed that biology would go on to explain better a lot of what he was observing, but that science just hadn't gotten that far yet. So he really did believe that, and I think he would overall be impressed and comfortable with a lot of modern psychiatry.
Well, let's use Sigmund Freud as the takeoff point for our discussion this evening, Neil, because I really want to talk to you, first of all, just about psychiatry in general. You and I have looked at the history of psychiatry and the history of medicine and medications at various times. For our audience's benefit, psychiatry and neurology actually started out as one specialty. Tell about how the two evolved and became two separate specialties.
Well, psychiatry and neurology are intimately related, and what happened is, I frequently refer to it as Descartes' error. Descartes was the great philosopher who essentially drew this distinction between the mind and the body. So he kind of separated the two organs, and that turns out to have been a great mistake. Coupled with that came along a lot of the Freudian ideas and a thinking that the two were really not related. It turns out that the mind really resides in an organ that we call the brain, and I tell my patients God gave us a neck for a reason, and it's to connect those two. They are intimately related. We've talked a lot over the last 12 weeks about symptoms of anxiety and depression frequently presenting as multiple medical complaints. Headaches, nausea, palpitations, rapid heart rate, sweating, dizziness, lightheadedness, GI problems. These are all medical, physical symptoms, but in many patients are the manifestation of stress, of anxiety, of depression. And so they really are intimately related. For a long time, psychiatry actually left the fold of medicine. That was a great mistake on the part of psychiatry. It kind of ventured off on its own into kind of a fuzzy, black box, touchy-feely sort of thing. Everybody has a picture of the analyst couch and talking about your mother. And now we've come back around full circle. So that modern psychiatry, a biopsychosocial model, a lot of better understanding about the brain, the receptors, the transmitters, and we are rejoining the fold of medicine, doing good studies, looking at dosing and outcomes, and all the same approaches that the rest of medicine uses. I actually think we can go too far that direction, and we can start to look at just the brain and forget the mind. The fact is we need to look at both, that our psychology, our emotional state, as well as the biology part of it, are both important, and frequently to achieve good mental health and balance, we need to have both of those out on the table and being addressed.
Let's talk a little bit more about the perception of psychiatry and the psychiatrist. You made reference to the cartoons sometimes seen in magazines with you always see the psychiatrist in the chair beside the patient on the couch, and I've been in hundreds of psychiatrist offices in my work, and I have yet to see a couch in any office. So relating to that perception, one commonly thinks about a psychiatrist interviewing a patient and beginning with some request to talk about their childhood or their relationship with their mother, how much of mental illness really has anything to do with one's childhood or getting along with your parents?
Some does, but most doesn't. Obviously, we are all a part of our upbringing. That includes our relationship with our parents, our sibling, our environment in general, as well as our biology, the genetic code that we carry coming from both parents. And so these two come together. The nature and nurture are married, and there's, depending on the illness, how much influence from a genetic versus an environmental perspective we think is actually contributing to what we see. Mostly when a psychiatrist sees a patient, like any other medical doctor, and we are medical doctors, we initially get a history that focuses on the patient's symptoms, their immediate complaints, basically what it is that brings them into our office at that time. We should also get some social history, medication history, family history, psychiatric history, trying to gain some knowledge about the genetics, the other things the patient is bringing to the table, but we tend to focus initially on the immediate problem.
Talking about the immediate problem, though, when I go to a medical doctor and he talks to me or she talks to me about what brought me into the office, they'll do some tests, they'll check my blood pressure, my height, my weight, they'll do just some kind of testing, there's some conversation. We talk about the diagnosis of a disease. If I go to a medical doctor, it's high blood pressure, perhaps, diabetes, all measured by tests. In psychiatry, it's a little bit different. You and I, in the past 12 weeks or so in our shows and our conversations, we've talked about making the right diagnosis, but quite honestly, is the diagnosis really all that important? Don't psychiatrists really just treat symptoms?
Well, I hope that they don't. Unfortunately, sometimes they do, and I would argue the same is true for the rest of medicine. If you look at actually how good psychiatrists are at diagnosing illnesses, we are as good, if not better, than any other branch of medicine, regardless of the testing, so that while the public seems at times to put a lot of emphasis on some quote-unquote objective tests, tests are only good as the limitation of the test and the person interpreting them. Now, you might remember going to your doctor's office with a sore throat, and the doctor looks in your throat and says, well, it's probably strep throat, that's what's going around. Now, they could order a culture and send that off to the lab and be certain as to what the bacteria is and what its resistance is to a variety of antibiotics, but they don't usually do that. Usually they get a good history, they use their knowledge and their observing powers, and they make a provisional diagnosis, like strep throat, and they begin to treat it, penicillin, zithromycin, whatever, and look for how that responds. That's really what we do in psychiatry, and we're just as good at it, so that by using a defined set of criteria, and we use the Diagnostic and Statistical Manual of the American Psychiatric Association, we actually are quite good, if we get good history, at reaching diagnostic certainty and consensus. Certainly we have to treat the symptoms and help the patient to feel better. One of the things that happens in psychiatry, a little bit different than most of medicine or other branches of medicine, is that we see our patients for longer periods of time, both at each visit as well as over a longer period of time. And so sometimes the problem changes. You might come in initially with a complaint of insomnia, not sleeping well, which to me might make me think about depression as a possible diagnosis. But as your depression settles down, some of your anxiety or obsessiveness or stress or work, other things come up, and we have to keep shifting and changing and moving with our patients, as opposed to that sore throat, which just ends at that treatment episode. We're going to be going to break, and we'll come back after break.
On the other side.
Exactly.
Real Life Solutions. Voice America Health and Wellness.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Videos de aprendizaje de inglés, máxima calidad.
Nunca escucharás a alguien vendiendo educación en la calle, pero con programas familiares gratuitos sí puedes obtener la educación que necesitas. Llame al 1-877-326-5481 para información sobre programas gratuitos de educación familiar.
Mira, vengan aquí, obtengo un mejor vocabulario en inglés garantizado.
El primer paso a una vida mejor. Un mensaje del National Center for Family Literacy y el Ad Council.
Achieve exceptional levels of health and fitness through integrating the very best in fitness, nutrition, and healing. Tune into Total Fitness with fitness, nutrition, and healing coaches Katherine Kerrigan and James Williams. Each week, get inspired to exercise, eat and rest in harmony with your body's needs, and take advantage of effective natural healing methods with in-depth cutting-edge information and advice. Get fit, get healthy, get motivated, and get real with Total Fitness, broadcasting every Friday at 7 a.m. on Voice America Health and Wellness.
Are you tired of being tired? Are you sick of sitting around while life passes you by? You can get back on track by tuning in to Voice America Health and Wellness every Monday at 12 p.m. Pacific Time for Attracting Abundance, the Energy of Success with Carol Look. Attracting Abundance is the program that empowers you to finally break through your limiting beliefs and blocks and shows you how to succeed in all areas of your life, from improved financial abundance, health and weight problems, as well as your relationships. Don't wait another week to be joyful. Listen to Attracting Abundance, the Energy of Success with Carol Look, this Monday at 12 p.m. Pacific Time, right here on Voice America Health and Wellness.
A fresh look at today's health. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back to the show. This isn't Dr. Kaye. This is Jay Birch here with the expert. I am asking the expert lots of questions this evening. We started on a conversation about psychiatry. Remind our listeners that the call-in number tonight, and we welcome any questions, concerns, or comments. The call-in number is 1-866-472-5792. Maryland. Oh, looks like we do have a caller here. Lee, are you on the line? Can you hear us?
Yes, I can.
How are you this evening?
I'm fine, thank you. How are you?
We're doing fine. What question do you have for Dr. Kaye?
I've been listening to your shows through the weeks, and one thing that you haven't really hit on is the stigma of mental illness. I mean, every time you fill out a job application or anything, you're always asked, have you had or been treated for a mental illness? And I guess I kind of want to hear your thoughts about that and how one goes about debunking that.
That's a great question, Lee, because that was about two questions down on my list for Dr. Kaye. So great mind reading there. I guess I was sending those vibes out over the air. Neil, would you like to answer that?
Absolutely.
Is there a stigma anymore?
There is definitely a stigma, and it's a shame that there is. What I'd like to say, first off, is that we are breaking the stigma gradually for a variety of reasons. Better treatments, better accepted, better effective treatments make it more acceptable. About 20% of Americans are now getting treatment for mental illness of some type, so the use of medications is very high. When you see things like medications on all of the leading soap operas and CSI series, again, this helps. Direct-to-consumer advertising by the pharmaceutical industry, again, has made treatment more accessible. Yet there does remain stigma. A lot of it based on culture, how you were raised, the pick yourself up by your bootstraps kind of approach that a lot of people think they need to do, all very real issues. Depending on the illness, I think also that influences the stigma. There's certainly more stigma about a serious mental illness like schizophrenia than about something like attention deficit disorder, where every kid in America seems to have it and everybody's getting medicines in school. As the population demographics change, the stigma actually does go down, so that when you have a population in their 20s and 30s, many of whom have had treatment or whose children have had treatment, they're much more open to it than, say, older people who, toughed it out through the depression of the 20s and 30s and think everyone should be doing likewise. So you get that issue. Another issue is within medicine. There really is a difference. Psychiatry, obviously, much more open to our own issues, yet one of the biggest areas of stigma out there is in the medical world, where a lot of patients may be comfortable with issues of mental health and mental illness. There's actually a lot of physicians who still actually discriminate in a variety of ways. They don't see heart disease in women. They think of it as a men's illness. They think about mental illness differently than physical illnesses than they should. So the stigma is still there. A lot of national organizations working to break stigma, and a lot of places in the employment world, you mentioned job applications, also some shifts there because of some of the federal legislation, some of the rules that the government has put in. Employers no longer allowed to ask about mental illness until after a job applicant has been offered a job, and then under the ADA, they have to make an accommodation for that. They can't screen you out in advance. So there's been some changes in federal law to help protect people, but we have not completely won the battle. I think we're helping with it. Did that address some of your questions or thoughts?
Yes, thank you very much.
Great, thank you for calling, and I'm glad you've been listening.
Thank you. Bye-bye.
All right, Neil, coming back, before we went to break, you were discussing the role of the psychiatrist in diagnosing a specific mental illness versus just treating symptoms. And, you were talking about doing that in an interview. So why don't you elaborate on that, because I think you also wanted to bring up something about addressing side effects.
Yeah, I think that getting the diagnosis is important. Obviously, we want to help the patient to feel better, but simply addressing the symptoms is not the right way to do it. In any branch of medicine, it would be like if you came in and you had a headache and a fever, and I said, well, geez, we'll give you some aspirin and take care of that, and I never never diagnosed your infection and didn't treat your infection. I might alleviate some symptoms temporarily, but I've not done you a service, and you're going to be back because you're not really treated. Simply treating symptoms isn't the way to do it. Part of the way you get to the right treatment is to actually know the diagnosis and then to use the evidence-based medicine that we have, the good research that we keep doing to try to address things in the most logical, scientific manner. So we really do want to treat your diagnosis, but we also want to treat you as a person, because you're not necessarily the middle of the bell curve in some drug study. You're an individual, and we have to learn about your system, what you tolerate, what you don't tolerate. Do you respond the way the quote-unquote average person does, or are you particularly sensitive or particularly resistant to whatever our treatment approach is? The other thing that comes into this whole area is we diagnose not just illness. Sometimes we have to diagnose side effects, and people don't always remember this. We might start a treatment, and you might then come in with a new symptom. Question then arises, is this a side effect of medication? Is this a new symptom related to the disease progressing?
Can you sort of give us an example? You're diagnosing depression, for example. My originating symptom is I'm having a sleep problem, so that helped you make the diagnosis of depression. What might a new symptom be?
Okay, so we start on an antidepressant medication, and now you come in and you have weight gain. And you went online because you're a good, smart person, and you read that weight gain is a possible side effect of your medication. So you've already diagnosed that the problem with the weight gain is it's that damn medication the doc gave you. And, well, that could be. That's a possible. It's also possible that since you're not depressed, your appetite is picked up, and when people are depressed, they frequently don't eat as much, and when they're less depressed, they start to eat more, and now you're actually gaining weight because your mood is better and treatment is working. It also might be that you're actually now more depressed, the medication isn't yet working, and you have developed another symptom of depression, which might be carbohydrate craving. So there's more than one possibility for why this new symptom is present. Maybe it's a side effect, or maybe it's not. We need to try to figure that out. I like to try to do that together. but there is a great tendency by everyone to label this change as a side effect, and that can be a problem, particularly from people with anxiety disorders. Anxiety patients frequently develop side effects that they read about. The more side effects that they read about, the more symptoms they develop. And in fact, they may have 10 or 15 symptoms. We tell them they have an anxiety disorder. We begin treatment, and the week later they come in for their follow-up visit, and their symptoms are the same, but now they will tell you that all those symptoms are actually side effects of the medication, and they somehow forgot that they actually had those exact symptoms originally, and that's why they began the treatment. So there can be sort of a morphing that sometimes occurs, and we need to figure out whether or not something is truly a side effect or not. And of course, if it's a side effect, is it transient and will it remit by itself? Is it such a problem that we need to change strategies? Or is it something that you can tolerate and live with for the greater good of your underlying illness or condition?
Neil, it sounds like I'm glad you're the expert, because this side effect symptom thing seems to be simple in my mind, but it certainly got more complicated. But you bring up a great point, because the symptom that you mentioned is anxiety, and if there's one term that's come up repeatedly over the last 12 shows, it's anxiety. We did a whole show on anxiety spectrum disorders, and yet anxiety is a symptom of a whole lot of other mental illnesses. How often, just to remind the audience, how often does anxiety exist comorbidly with, say, depression, or with obsessive compulsive disorder is an anxiety spectrum disorder, with bipolar disorder, for example, and how does that complicate the treatment?
Sure. Well, anxiety is a traveler. It goes along with pretty much every illness you can imagine. Certainly in some of them, like depression or bipolar disorder, 75% or more of patients will have anxiety along with it. Many of those people will actually meet all of the criteria to have a diagnosis of a separate, distinct anxiety disorder. Generalized anxiety disorder, or social anxiety, or social phobia, or panic being the most common. But they're travelers, and you see this throughout medicine. About 75% of patients who show up in a primary care physician's office meet the criteria for an anxiety disorder at some point. So, again, very, very common. We see anxiety all over. It complicates the treatment because the patient may focus on that, or you may not experience a lot of your anxiety when you're so depressed, but once your depression is better, the anxiety might actually come to the surface because now you have enough energy and wherewithal that now the anxiety becomes your new primary problem or condition that we need to be addressing.
So in that way, does it affect the outcome of treatment?
It does. Obviously, anxiety worsens outcome and complicates treatment because we need to be able to address now possibly two conditions, not one, and anxiety can be very difficult to treat. Obviously, most patients with anxiety do very well, but there are always challenges. And again, anxiety patients, one of the challenges is a increased susceptibility, an increased proneness to developing medication side effects. And so anxiety patients tend to be more sensitive to medication, more likely to develop side effects or unusual side effects. And a lot of these things, frankly, are placebo-related, meaning that they would have these symptoms regardless, but because we've done an intervention, it becomes the focus, the explanation for what it is that the patient is experiencing. That makes it more complex and obviously constrains some of the doctor-patient trust. That's also important to treatment. We're going to be going to break, I think, just about now, and we'll come back after break with more questions.
Opinions, options, answers. Voice America Health and Wellness.
Stay mentally, physically, and emotionally fit with Younger Every Day. Hosted by Dr. Bob Payson. Broadcast every Friday at 10 a.m. Pacific Time, 1 p.m. Eastern Time on the Voice America Health and Wellness channel. Younger Every Day will offer you alternative solutions for a variety of health issues, all backed by clinical, scientific, and medical data. Dr. Payson and other expert guests will inform and inspire people of all ages to look and feel better. Younger Every Day. Think clear, feel strong, grow younger. With Dr. Bob Payson, right here on Voice America Health and Wellness.
Women, do you feel that you're too old to be active, too old to be beautiful, too old to have fun, or too old to be fabulous? Well, if that's what you think, then there's good news for you. You're wrong. Tune in to Voice America every Wednesday at 8 a.m. Pacific Standard Time for Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell. Aging Outside the Box is a fabulous, fun program that gives you every reason to feel greater than you ever have. Host Shirley Mitchell and OE Cruiser Small will cover phenomenal topics such as women's issues, health, diet, exercise, nutrition, faith, travel, and many other concerns for women of all ages. Feel young, feel smart, and feel fabulous by tuning in to Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell every Wednesday at 8 a.m. Pacific Standard Time, right here on VoiceAmerica.com.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Step into a healthier you. Voice America Health and Wellness.
Welcome back to Psychiatry Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back. Dr. Kaye and Jay Birch, Psychiatry Ask the Expert. Call in tonight, 1-866-472-5792. Jay and I are discussing a whole lot of things in psychiatry. We're going to take questions on any topic tonight. And, Jay, you had the next one.
Yes, Neil, before we went to break, we were talking about anxiety as a traveler symptom, and it occurs to me that, mental illness itself sometimes is a traveler. Talk to the audience about medical illnesses that frequently have, as a traveler, a mental illness component.
Okay, boy, great question, and we're going to do a whole show on this sometime. There are a variety of medical illnesses that are known to have high comorbid mental or psychiatric symptomatology that go with them. So times where we're likely to see them together. Some of the gastrointestinal diseases like ulcerative colitis, very common to have a stress component. Heart attacks, depression after heart attack, remarkably common. Parkinson's, MS, multiple sclerosis, that is, dementia syndromes, again, very much related to depression. So there are some diseases where it's normal for us to be involved together with comorbidity, 50-70%, not uncommon. Let me throw cancer and also AIDS, HIV onto that list. In fact, frequently the presenting problem in AIDS or HIV will actually be depression, and the psychiatrist may be the one to pick up that this is depression, but there's also something organic going on with this patient, cognitive problems associated with the depression that make us think this isn't just psychiatric.
So when you see this type of patient, do you excuse the depression or whatever the mental illness might be to defer to the treatment of the medical illness, thinking that once the cancer is remitted, once the ulcerative colitis has subsided, once somebody's diabetes is back into normal range, that their depression, their anxiety will go away?
No, not at all. We need to treat both conditions at once. We are on the same footing as our medical colleagues. Both illnesses, both presentations need to be addressed simultaneously to get the best outcome. Sometimes remission of the medical illness will be all that's necessary. Usually that's not the case, and a lot of these medical illnesses tend to be chronic in nature. So it's not just an acute appendicitis, snip, your appendix is out and you're done. Diabetes, long-term illness, long-term treatment. Cancer, long-term illness, long-term treatment. And so these lifelong chronic illnesses are much more likely to wear the person down and to have this comorbidity co-association.
So I think what you're talking about is really reflected in data that we've recently seen with some of the antidepressants, where people who suffered heart attack, their depression was treated with an antidepressant, and compared to people who had heart attacks and weren't treated for the depression, the people who got treated actually had lesser recurrence of those heart attacks. Is that correct?
Absolutely. This is a very important point. You're referring to what we call the STAD heart study, very important study done by Dr. Glassman. And there's some beautiful studies, again, Glassman did them looking at heart attack as well as stroke, and also in the cancer area. There's some very good studies that showing addressing the mental health, emotional side of the equation brings about better recovery, reduced morbidity and mortality from the medical illness itself. That simply treating the medical illness isn't sufficient. And again, the head, the mind, the body are all connected. We need to treat the whole person. And again, this error I talked about in the beginning part of the show, separating the mind and the body, a real error that was made early on by the philosophers who laid the groundwork for modern medicine, and we're still paying the price of that disconnect.
Okay, so with the healthy mind, you get your outcome for a healthy body is better and more likely.
Healthy mind, healthy body definitely go together. It also impacts very much on the treatment that a patient may get. One of the things I do as a psychopharmacologist, obviously I'm a physician first. I have to go to medical school and take some surgical rotations and all of those things. It's not simply about prescribing psychiatric medications. A good psychiatrist needs to understand the medical illnesses as well. And then part of what we will do when we're looking at the medications we pick is to look for medications that either won't hurt or exacerbate or worsen the medical symptoms the patient is having.
I think you're referring here maybe in a sideways manner to potential drug-drug interactions. Why don't you explain what that is to the audience?
Sure. It could be drug-drug interactions where one drug may actually get in the way of another drug, so that you may take one drug and then we give you a different drug, and, well, that drug may inactivate the first drug, and so we might actually do you harm that way. It might be that our drug has a side effect that is not good for your condition. I see a fair number of patients who have head and neck cancer, and as a result of that, a lot of these people have trouble with dryness because of their cancer and the surgery and radiation. Well, if we give them drugs that are more drying as a side effect of our psychiatric drugs, we're worsening their medical condition with an antidepressant that's drying as opposed to picking one that's not drying. And so we certainly want to be aware of both effect and side effects. There also may be times where we can pick a drug that helps the medical condition. You mentioned the heart attack issue. In the world of antidepressants, there is an antidepressant, sertraline or Zoloft, which has been shown to actually have a positive effect on reducing future heart attacks or strokes, and it's unique to that compound. And so in a patient after a heart attack, to me that's a drug of choice because it not only doesn't get in the way of the cardiac meds, it actually is synergistic. It helps the patient's medical outcome directly as well as indirectly through alleviating their depression. So one of the things psychopharmacologists do is we spend a lot of time looking at that long list of medications the patient brings in and try to look for interactions, both positive and negative, and what is going to be the best overall approach for this individual.
Talking about medications, and let's take a general view here, but looking at the medications you have today at your disposal, the psychotropic medications, and your knowledge of pharmacology, what are the advantages of the current generation of medications over maybe what you were trained on some years ago, if there are any?
There are some dramatic differences in advances. I tease that, 20 years ago, we were basically using leeches. In the world of antipsychotics, we had just a handful. We had one mood stabilizer when I started. We had none of the modern antidepressants. So there's been a huge change, and this is in every area of medicine. I would also point out that in another 10 years, we'll look back and think, gosh, what we did in 2005 was archaic and leeches again, basically. The goal of new medication is to develop better efficacy, or at least equal efficacy, to the older medications, but always trying to reduce the side effects. Side effects of medication are a tremendous problem. Obviously, each drug has a different side effect profile, but if I were to characterize newer medications, their goal is to be more effective and better tolerated. Usually that's the case, but not always. So usually we think newer is better, but that's not always the case. Newer sometimes is simply newer, and that's all. So it's up to the doctors to learn, the patients to help them figure out which actually is a better medicine overall out in the real world. But our goal, again, better efficacy, fewer side effects. Certainly in the area of antidepressants, we have achieved some great breakthroughs, one of which is that the newer antidepressants are much less lethal in overdose. Some of them are not lethal at all. In the old days, we were giving depressed patients pills that in overdose could be lethal, and so in some ways we were handing patients a loaded gun and saying, well, be really careful with this because it can help you and protect you, but if you take too many, it's going to kill you. We have much less of that issue now. Our drugs tend to be less cognitively impairing. They tend to be less sedating. We're shooting for less weight problems, so more weight neutrality. On the other hand, the one side effect we certainly have picked up in the antidepressant world is sexual side effects, something we obviously don't want, but it's been a real problem with the newer class of drugs. But compared to things like weight gain or suicidality and overdose, it seems more attractive, especially in the acute phase of depression. In the world of antipsychotics, much less risk of movement disorder, but different risks of metabolic syndrome, the risk for high lipid, cholesterol, triglycerides, and blood sugars with some of the newer drugs. Always looking for better balance. In the world of anti-anxiety drugs, real effort, and I mentioned this in my radar segment, real effort to try to come up with rapid-acting minor tranquilizers that don't have the addiction-abusive problem of the older drugs like Valium and Xanax that certainly were effective but carried a real risk of abuse and dependence with them.
Now, how do you feel about the side effects of your area of medicine, which is psychopharmacology, the psychotropic medications, versus the medications that the general practitioner, the family practitioner, the internist has at their disposal? Would you say your current generation psychotropics is equivalent in efficacy and fewer and less side effects than general medicines, or?
I would say that we're few. I think we're actually pretty comparable. First off, I would remind the audience that the vast majority of psychoactive medications are, in fact, prescribed by general practitioners, OBGYNs, family docs, primary care docs, whatever you call them. That they're the big prescribers, not the psychiatry specialists. But overall, rates of side effects in our offices and their offices are very comparable. And again, they struggle with trying to develop newer, better tolerated, equally or more efficacious drugs the same way that we do. We're going to go to break and come back for the last segment after break.
Helping you make informed decisions for your life. This is Voice America Health and Wellness.
Hey, how you doing? Educational videos, top quality, right here.
You'll never hear anyone selling education on the street. But with free family learning programs, you can get the education you need. Call 1-877-FAMLIT1 for information on free learning programs. 1-877-FAMLIT1.
Check it out, check it out. Your GED right here, guaranteed, ma. Come on, check it out.
Free family learning programs from the National Center for Family Literacy. Brought to you by the National Center for Family Literacy and the Ad Council.
When you combine energy secrets from ancient China and the latest breakthroughs in medicinal science, you get power healing with Dr. Shaw. Heard every Friday at 5 p.m. Pacific Time on Voice America Health and Wellness. Each week, Dr. Shaw will bring you another step closer to the expanding world of body-space medicine. You will quickly learn and appreciate how power healing is a perfect alternative to hospitals and expensive drugs. Take a step beyond modern medicine every Friday at 5 p.m. Pacific Time with Dr. Shaw on Power Healing, right here on Voice America Health and Wellness.
Growing Up in America explores the challenges, risks, benefits, and differences this generation of children face each day. Hosted by veteran pediatric emergency physician and father of 4, Dr. Charles Muzica, this show is for parents, teens, and children. It crosses each generation. By exploring the unique aspects of matriculation within this current generation, we hope to find answers and ways of optimizing this experience for today's generation. Growing Up in America with Dr. Charles Muzica broadcasts each Tuesday at 2 p.m. Pacific, 5 p.m. Eastern on the Voice America Health and Wellness channel.
Opinions, options, answers. Voice America Health and Wellness.
Welcome back to Psychiatry Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back, everybody. This is Jay Birch. I'm here with Dr. Neil Kaye, Psychiatry Ask the Expert. Welcome your calls. If you would like to call in with a question, the number is 1-866-472-5792. Neil, I got to ask you this. We've all been in an office somewhere waiting to see a physician, and someone in a nice suit or a very sharply dressed young lady comes in, and they somehow get the physician's attention and go in ahead of us. These are the drug representatives. Tell the audience what actually happens when a drug representative comes to talk to a psychiatrist. What goes on? What do you talk about?
Well, drug reps are an integral part of the practice of medicine today. Both goods and bad about them. Obviously, they interrupt schedules. They can be an annoyance sometimes. On the other hand, they really are an asset overall. Every doctor develops their own way of dealing with them. Some forbid them and don't see them. I actually embrace them. Drug reps, if they do their jobs right, are a source of education. That is, they should bring material and value to a doctor, and the good ones do that. They will bring us articles or research. Obviously, they are part of marketing and do try to influence doctors. Good doctors aren't terribly swayed by that, and if we see one rep from each company every day, well, at the end of the day, that all balances each other out, but we've got all of the articles from all of the companies at that point. They also provide samples, and this is a big issue. We need samples. A lot of our patients want samples. It allows us to start patients on the medication free of charge. See if it actually works, if you tolerate it, if you're having side effects before you or your insurance company go out and invest in the drug. And so that's certainly an important factor as well. Their real purpose, as I see them, and what I try to get from them, really is education. Now, doctors shouldn't learn only from drug reps, and of course we are cautious about the education from a drug rep, knowing that it might be biased as a source. On the other hand, again, we hear from their competitors as well, so the bias is when they're there, come out pretty clearly, and doctors develop long-term relationships with drug reps. They easily learn who to trust, who are the better ones, who are the slick marketers, and I hope not too many doctors are actually overly influenced or somehow misinfluenced by drug reps. Overall, I support them. I think that we should be sharing time because, again, we also get a chance to educate the reps, and hopefully they can spread better information back out into the community.
This education that you talk about brings up the subject to my mind, talking about drug company research. So it comes as a question to me, how accurately do the patients who are recruited for drug trials, drug clinical trials, how accurately do you think they represent patients that you see in your office every day? And how can you draw conclusions based on what a drug rep might show you about a particular trial or
Sure.
study.
Well, as you know, I do not only clinical work, but I've actually done drug research both for the industry, the pharmaceutical companies, as well as for independent organizations for over 20 years. And what I can say is that it varies from study to study, but frequently the research subjects and the patients we see in the real world are very different. And so that applying what comes out of a drug study to the real world is actually very difficult. Patients in drug studies have to be, as I say, squeaky clean. They're supposed to have only one diagnosis, not multiple diagnoses. They frequently are not allowed to be on other medications that are commonly used out in the real world. They're not allowed to drink or do drugs, which a lot of other patients really are doing. And so they tend to represent a milder form of most illnesses, and they're not completely realistic in that regard. And so what we learn from them needs to be tempered, and it often leads to package inserts and instructions that aren't really what turn out to be the best way to use a medication or treat a person out in the real world. On the other hand, that's the way the system is designed. People at the FDA have decided that this is the best way to do it, although a lot of us are more cynical about it and think there might be better ways. We also rely on placebo-controlled trials, and people frequently don't realize that there's a lot of problems with placebos and placebo trials. Placebo has high side effect rate in a lot of studies and can complicate things as well.
Neil, on that issue of trials, and you mentioned leeches a little bit ago, where do you think psychiatry is headed in terms of medications or treatments in the year 2016?
Well, I think down the road we're going to see further development of more pharmaceuticals. In that regard, we'll see some new drug classes develop. I think we'll see a real advance in the world of actual mood stabilizers, as well as some rethinking about the difference between unipolar regular depression and cyclical or bipolar depression. I think that will be a big change. We'll see the advent, I believe, of non-addicting drugs for both attention and anxiety, far better than what we've had. We're going to see an advance in drug delivery systems, where we've relied heavily on pills in the past, which are more prone to side effects because they have to get to the acid of the stomach and the metabolism of the liver. The increased use of patches, inhalations, nasal applications of drugs, especially to get into the brain. We're going to see more in the way of drug delivery systems, better drugs for weight, better drugs for attention, apathy and motivation, and of course a great hope for cognitive enhancers, both for people with dementia as well as for normal people who just want to be smarter.
Okay, that's great. You know, we've talked about the mind-and-body connection. We talked a little bit about, we had a caller, Lee from Maryland, ask us about mental health stigma. I guess one of the things I'd like for the audience to hear one more time before we have to close the show this evening is talk about the outcome for the treatment of mental illnesses. What's a realistic expectations? Because this certainly becomes part of the issue with psychiatrists and managing medications and managing their patients. What should patients really expect to be the treatment outcome of a mental illness?
Well, it varies a little bit with each of the mental illnesses, but as a generalization, outcomes are very good. Very good means, say, a 50 to 60% reduction in severity of symptoms in 50 to 60% of patients with the first drug intervention that the psychiatrist picks. So if we can be right two-thirds of the time in our first attempt, we're actually doing remarkably well, and frankly as well as any other branch of medicine with their disorders.
How important is that first attempt relative to the risk of recurrence? Because I've seen some stuff about depression where if they don't respond to the first drug, they're less chance of responding down the road.
Well, there's less chance, but certainly you don't want to give up. The first attempt is important because it does set the stage for future trials. It also builds an expectation in for the patient. Unfortunately, especially in things like depression, a lot of patients get weak first attempts. they're not treated aggressively enough in the first round, leading the patient to incorrectly think that they are refractory or untreatable, or that their case is somehow hopeless. And in fact, if they had a more aggressive, better first treatment approach, they probably would have gotten better. It's remarkable how many people will respond to something that they failed earlier on if you give it to them at a higher dose for a longer duration and stick with it. So abandoning or switching treatment too early on is one of the great mistakes that doctors and patients fall into.
How about your expertise in geriatric psychiatry? What should the baby boomers be looking for in terms of mental illnesses they go into their retirement years?
Absolutely going to increase. We know that particularly, again, depression, increased risk as we get older, so need to be expecting that they're going to be a little more open to treatment because of their experience in their younger years. So we'll definitely see a booming business in that area.
Okay. Neil, we're coming up on the close of the show, and I'd just like to say thank you very much for this opportunity to do this show with you over the last 12 weeks. I will not have the chance to be here next week, but it's been great, and you're doing a great service to the public out there, and it's been my pleasure to participate. Thank you.
Well, thank you, Jay. Glad to have you as my co-host for the first 12 weeks here. For the audience, if you or someone you know might be experiencing mental illness or emotional problems, help them get professional help and support. You be the family and love that they need to be. Let the doctors and professionals take care of the treatment side of things. Next week, we're going to have Dr. John Townsend with us, a neurologist and expert in sleep disorders. We're going to talk about that interface of psychiatry and neurology as well as sleep disorders. Our favorite websites, ADAA.org, HealthyMinds.org, NIMH.org. And thank you for listening to Psychiatry Ask the Expert. We'll see you next week. Bye-bye. Have a good one.
Good night, all.
Thank you for listening to Psychiatry Ask the Expert. To learn more about Dr. K, visit courtpsychiatrist.com. Tune in next Tuesday for another hour of Psychiatry Ask the Expert with Dr. Neil K.